Good afternoon, everyone. So, actually, Team KB has taken up the mammoth task of keeping you hooked during the lunch session. So, it's going to be a challenge on our part. Hope we can deliver some interesting points. So, I'll be covering aesthetic assessment of the face. So, what are the basic steps involved is there is patient history and systemic evaluation, expectations and goals that the aesthetic physician must discuss with the patients, photographic documentation preferably done in the natural head position, a psychological assessment which must be thorough from the end, from our end, a basic ophthalmic examination and detailed facial examination which is called the facial analysis, which can be broken into three segments: the orbitocelaton and globe, forehead and upper eyelid complex, lower eyelid and mid-face complex. So the aesthetic physician must have an educated eye, and the face must always be analyzed both as a single unit as well as in components. The periorbital region is a key defining feature of our face, because eye contact naturally draws attention towards this zone. So what are the broad pathologies that you need to rule out when it comes to patient history? Thyroid eye disease, the recommended disease quiescence period of at least 6 to 9 months prior to rehabilitative procedures. Myasthenia gravis, you need to establish the systemic status of the patient, which is conducive for surgical candidacy. If the patient is on any pre-existing medications, any prior refractive procedures, and any prior aesthetic surgical or non-surgical procedures that the patient has undertaken. Within ophthalmic examination, we have visual acuity, ocular movements, dry eye syndrome, and tear drainage system malfunctions, if any. So coming to the orbitoskeleton and globe, the facial bones are basically forming the framework and the source of attachments for ligaments and muscles that define the face. The chief bones amongst them are the zygoma laterally and the maxilla medially. A prominent malar eminence is considered youthful. Aging is associated with the resorption of intraorbital rim, leading to malar hypoplasia. So what you can see in this young individual is the vector that you can see green in color, and the vector over here that you can see red in color. So essentially, if you drop a line from the supraorbital rim to the infraorbital rim, it's considered to be positive if your cornea is lying posterior to this line, and that marks the sign of youthfulness. Whereas with age, the vector turns negative when the cornea lies anterior to this line due to the resorption of the infraorbital rim. Now, the two things that you need to pre-aesthetic treatment evaluation is the exophthalmos, which needs to be ruled out even as a part of the thyroid eye disease or due to any previous aesthetic procedures that patient has undergone, and enophthalmos, specifically superior sulcus hollowing, which is a sign of tired or aged look. Now, we can measure the anterior globe prominence using the Hertel's exophthalmometer. How does this factor in the surgical planning is that in patients of exophthalmos, the position of the lateral canthal fixation in case of lower eyelid blepharoplasty possibly requires a higher placement and needs to be tailored according to the degree of the prominence. The second is the forehead and the upper eyelid complex. These are the various components of the forehead: the brow, the brow fat span. Tarsal plates show, when visible, is considered to be a sign of youthful face. The lacrimal gland, the margin reflex distance 1 and 2, that plays a role when you are evaluating for any pre-existing ptosis. Canthal angles, lacrimal drainage system, lower eyelid height, and inferior orbital rim and retaining ligament. So the parameters can be broken down into skin, rhytids, brows, and eyelid. In case of male pattern baldness, wherein there is a receding hairline, these kind of patients, if they are undergoing any kind of surgical treatment, can benefit from pretracheal incisions. So male versus female brow position. The normal male brow lies along the superior orbital rim and is relatively fat, whereas the female one lies slightly above the supraorbital rim, the highest point being located laterally, could be either at the level of the lateral limbus. And why is this important is because if any kind of aesthetic treatment the patient is undergoing any evaluation, we must try to restore the normalcy and not give a relatively surprised look. Brow symmetry, any pre-existing asymmetry should be noted so that post procedure there is no dissimilarities between the patient expectation and the physician's outcome. Brow ptosis. So with the downward gravitational pull as well as the soft tissue laxative that factors in with age, we can see brow ptosis, and that can be seen as flattening and the loss of definition. One can also see in case of brow ptosis there will be a prominent frontalis overaction which leads to horizontal forehead furrows. So coming to rhytids could be static or dynamic. The dynamic rhytids normally benefit from muscle denervation procedures like botulinum toxin. The frontalis gives us the horizontal forehead rhytids. The glabular lines, which are vertical 11 in shape, are because of the corrugator supercilii. The orbicularis gives us lateral crow's feet. Bunny lines across the nasal dorsum are because of the procerus. And there are the other lower face lines, which are the nasolabial lines, the perioral marionette lines. So how do you elicit this? You'll have to elicit the patient to perform various facial expressions. Patient will have to raise the eyebrows, grimace, smile. So all the facial muscles, their actions need to be elicited and pre-recorded before any procedure. Upper eyelids, droopy, wrinkled or tired. So dermatochalasis needs to be evaluated beforehand. It could be primary because of the true age-related excess of eyelid skin. It could be secondary due to excess skin because of the sagging of the brows. So like I told beforehand, brow ptosis needs to be evaluated carefully, because in case of brow ptosis with patient who are having dermatochalasis, you can end up causing excessive excision of eyelid skin during blepharoplasty. With age, there is loss of integrity of the orbital septum in the upper lid, which can cause prominent eyebrow fat pads and displacement of the orbital portion of the lacrimal gland. That can also increase the bulk of the upper eyelid in addition to dermatochalasis. Blepharoptosis, we must evaluate any pre-existing ptosis in the primary gaze with frontalis relaxed and brow fixed in its natural position. This will definitely alter surgical planning of blepharoplasty. What you can see in this picture is an asymmetric lid crease that also needs to be carefully looked for, because in case of an asymmetric lid crease wherein it's upshifted, it could mark levator dehiscence. So in these patients with levator dehiscence and coexisting dermatochalasis, in addition to blepharoplasty, you may have to perform an LPS reinsertion. Lower eyelid complex and midface. So essentially there are three components that take place. There is orbicularis atrophy, there is weakening or laxity of the supporting ligaments, and there is aging of the weakening of the lower orbital septum that causes the orbital fat pads to prolapse. As you can see, the herniation of the orbital fat pad. So normally the lower eyelid is in continuum with the cheek, but due to age-related changes which occur in the mid-face, you can see that there is a convex, concave and convex pattern, which is a classic sign of the mid-facial aging and causing a prominent nasojugal on the medial side and a palpebromalar fold on the lateral side. Volume depletion and weakened midfacial soft tissue support causes the loss of lid-cheek junction contour irregularities. Lastly, eyelid laxity that can be evaluated with canthal laxity. You need to perform the pinch test and the snapback test, and that is the last but not the least in the evaluation of the aesthetic patient. To sum up, critical aesthetic assessment of the periorbital face includes knowledge of periocular and ophthalmic anatomy, understanding the morphological changes associated with age, sex and race, considering the orbital skeleton and globe, forehead and upper eyelid complex and lower lid and mid-face complex. Aesthetically pleasing and functionally sound interventions can be performed only when there is a holistic assessment. Lastly, we should have a smooth dialogue and patient communication. Thank you.
Thank you, Dr. Vatsalya. Indeed, aesthetic assessment is the first step. In all these procedures, not just aesthetic but even functional blepharoplasty, eyelid procedures, the counseling and the chair time are very important, because when a patient comes to an eye hospital, conventionally they think it's a cataract surgery. They come in and they go out and it's barely visible. Now with topical and laser surgeries, there's no redness in the eyes also. But here we are doing plastic surgery in a very delicate area, And if we are going with our blade unprepared, that's not enough. We need to know each and every detail, because no two cases will be similar, to the extent no right eye lower lid will be the same as the left eye lower lid. So assessment is very important.